Next, I would like to introduce Dr. Mary Ambach. She's coming to us out of San Diego. Dr. Ambach is Louisiana State University trained physician and double boarded and certified in physiatry as well as pain medicine. She's also double subspecialty fellowship trained in orthopedic, sport and spine, as well as orthobiologics and regenerative medicine. She has over 20 years of experience treating sports, spine, pain condition for various medical practices. She's an amazing physician. She's a wealth of knowledge. She's going to talk to us today about the literature review on PRP for tendons and cartilage. Dr. Ambach, thank you for being with us today.
Hi, John. Good morning.
Good morning.
Pretty early for us here in the West Coast.
Hopefully you've had your coffee this morning.
Trying to wake up. Okay, good morning, everybody. Let me share my screen. Let me know, John, if you're having any issues. Can you see that okay?
Looks great.
All right, perfect. Good morning, everybody. I'm Mary Ambach. This morning, I will be talking about platelet rich plasma and literature review of tendon and cartilage. These are my disclosures, which do not have any effect on the content of this presentation. So the most common condition that we see in our orthopedic practice that affects the cartilage is joint osteoarthritis. So I will be focusing the review on joint osteoarthritis for PRP. So I did a PubMed search on osteoarthritis and PRP, and I got 104 results of randomized controlled clinical trials on humans in the past 10 years. So there's a wealth of data for this condition. There's more than 50 randomized controlled clinical trials that show that PRP significantly relieves pain and improves function, and that PRP is superior to corticosteroid, hyaluronic acid or gel injections, and saline injections. There's a really nice infographic that Dr. Chris Centeno publishes, and it's the one on the bottom of your slide here. And it shows all the different RCTs. Each circle here represents a randomized controlled clinical trial that has a link to each of the studies. And it compared the knee osteoarthritis with the different comparators. So I provided the link if you want to see this infographic. It's a pretty cool resource. So what do we know so far with PRP for knee joint OA? So based on these studies, we know that PRP works best for mild to moderate osteoarthritis or Kellgren-Lawrence osteoarthritis grading 1 to 3. We know that they work at least up to about 12 to 24 months, although we know that in clinical practice it could last longer than that. With regards to leukocyte-rich and leukocyte-poor formulations, there's still debate on which bioformulation creates better outcomes. Leukocytes have catabolic and pro-inflammatory mediators that can negatively affect joint cartilage. However, this bioformulation also tend to have a higher cellular content, thus higher growth factors and higher cytokine content. And this can directly improve the outcomes as shown in the studies. The neutrophils, which has gotten a bad rep from the leukocyte poor camp, actually is helpful in so many ways. They have antimicrobial properties, they regulate wound healing, they're involved so much in tissue repair and specifically in angiogenesis through the toll-like receptors. The leukocyte-poor formulation, on the other hand, does have less inflammatory tissue response. Patients have less flare, but consequently, this results to less release of cytokines and growth factors and less angiogenesis. And so there's data supporting both formulations. There's also data that shows that maybe the leukocyte concentration do not play that much of a significant role. So at this time, there's really no consensus on which bioformulation works better. And this is a topic that will probably need its own session. We will find that these heterogeneous effects of PRP likely depend on a much more complex interplay of factors rather than just the mere presence or absence of white blood cells. More than these leukocytes, there may be other factors too in the cell differential and also where they sit on that buffy coat layer. So we'll also soon find out that maybe even platelet size may play a role in the outcome. Peter Evers and Jane Fitzpatrick from Australia will be talking about this and have submitted their work for publication. So I'm really looking forward to seeing this. But one factor that has gotten a lot of interest recently is dosing, platelet dosing. So let's look at that. This is one of the earlier studies that showed the effect of dose-dependent effects of platelet-rich plasma on chondrocytes in an in vitro setting. So they use a standardized lyophilized PRP powder to stimulate human chondrocytes, which they cultivated for 2 weeks. And they use different stimulation frequencies and also different concentration of the PRP powders. They did an analysis of the cell proliferation and metabolic cell activity and protoglycans and glycosaminoglycan contents. So this was the quantification of their cell number and metabolic activity. So if you look at the x-axis, you'll see the different PRP concentrations and the stimulation frequency. The y-axis has the cell number and the metabolic activity. So you can see that as the PRP concentration and the frequency increases, there's also a corresponding direct increase in the cell number and the metabolic activity of the cells. So their conclusion was that the chondrocytes exhibited a significant dose and time-dependent increase in the cell number and metabolic activity. There's also several studies that have been published in vivo regarding optimal platelet counts. So these are the studies that we know so far. I'm not going to include all of them, but these are one of the important ones. So you see, Patel's study showed that 5.6 billion of platelets did significantly better in pain and function than the group that had 2.82 billion platelets. Another study by Bill Bergen and Zach Bailowitz and their group showed that there were positive outcomes with the mean platelet dose of 5.5 billion. And the studies that did not show significant improvements had the mean platelet dose of 2.3 billion. So we're seeing a pattern here of at least 5 billion showing significant outcomes. And then we have Bansal's study that showed an absolute count of 10 billion platelets is crucial to have that chondroprotective effect up to 1 year in moderate knee osteoarthritis. And so we're seeing a consistent trend of greater effect and better outcomes with increasing platelet dose. So how about injection frequency? This is a study that was published in the Journal of Pharmaceutical Research International. They compared a single injection versus 2 injections, and their results showed that the single injection treatment group had the same results as the double injection treatment group. However, another study showed that the 3 injections had better outcomes than the ones that only got 1 or 2 injections. So we've got 2 studies that have different outcomes. But if we look closely at the dosing that they use, the single injection have 5.5 billion PRP platelet dose, while the 3 injections had a total dose of 4.6 billion. So as you can see, they both achieved that 5 billion minimum dose that the other prior studies have shown to have a good outcome or a minimum effective dose. So maybe that the platelet dose is more important than the injection frequency, or maybe that the cumulative platelet dose from multiple subtherapeutic injections can match that of a single high-dose injection. So it would be interesting to see how this would evolve. And I'm sure more studies will come out to give us more clarity on the dosing for joint osteoarthritis and other conditions. So this was Bansal's study, which was a double-blind, randomized controlled clinical trial, 150 patients comparing PRP versus HA. It was a 60 cc blood draw which resulted to 10 billion platelets in 8 cc of PRP. And he was able to show that the PRP group improved in the WOMAC outcome measures and also their pain and walking distance. So they found an absolute count of 10 billion platelets that is crucial to have long sustained chondroprotective effects up to 1 year in moderate knee osteoarthritis. They also showed that there was no significant MRI changes in these patients in both groups. So Bill Berrigan and his group did this systematic review and made an analysis. That was the first study to identify a potential dose-response relationship between platelet quantity and PRP effectiveness for knee osteoarthritis. So it was they included 26 level 1 studies, 28 level 2 studies, and 12 level 3 studies. 42 of these studies focus on knee osteoarthritis. They included 24 studies in their meta and regression analysis, and they divided the studies into low dose group, which is less than 5 billion, the medium dose group, which they identified as 5 to 10 billion, and the high dose group of more than 10 billion doses. So they found a dose response curve in the functional improvement, specifically the WOMAC scores, both at 6 months and at 12 months, pinpointing an optimal threshold dose of greater than 10 billion platelets for favorable clinical outcomes. However, they only found a small dose response curve with the VAS or pain scale at 6 months, but not at 12 months. Beyond knee osteoarthritis, there's less evidence in the other joints osteoarthritis. With regards to hip osteoarthritis, there were 3 studies showing treatment efficacy with a minimum platelet dose of 3.5 billion. However, the PRP only surpassed the comparators only if the dose is more than 10 billion. And they found positive outcomes at platelet doses less than 5 billion for glenohumeral joint OA and CMC joint osteoarthritis. So how about morphological changes? This PRP improved cartilage structure. This is something that we get to hear a lot from our patients. This is one of the questions that I always ask us. So this is what we have so far. So these are 2 studies evaluating not only clinical, but also MRI outcomes after PRP for knee osteoarthritis. And these were both 1-year follow-up. And their results showed that there was no changes in the thickness of the cartilage in most of the cases. At least in Halpern, it's more than 70 of the cases. And but if you look at the doses that they use in these studies, the first study used a 20 ml whole blood that resulted to a 6 ml PRP. And the second study used PRP that was 2 to 3 times baseline. So likely subtherapeutic based on the prior studies that we just discussed in the previous slides. But in spite of that, they found no loss of cartilage in 1 year, so at least it maintained status quo. And they found improvement in pain and function in these patients that were treated with PRP. This third study had, actually they did a really detailed MRI analysis of the patients that were grouped into 3 different groups. They compared the steroid group, the HA group, and the PRP group. And the results showed that there was no changes in the morphological parameters, specifically the cartilage grading, bone marrow edema, and the cysts. However, if you looked again at the dose that they used, this is a small dose, 1.5 billion PRP. Our previous studies are showing at least 5 billion to have good outcomes. So maybe that was a factor. However, their PRP group had improved MRI T2 values after 12 months when they compared it to the steroid group. So still a lot of things that we need to know, but these are initial data that at least is still showing that there's not a lot of cartilage structure. There is one study though, this one. So this study actually showed some positive change with the MRI compared to their control. So the control was the exercise group and the treatment group was exercise and PRP. So this was a double-blind randomized controlled clinical trial, 46 knees, mild to moderate osteoarthritis. They did an 8-month follow-up on these patients. They used a leukocyte-rich formulation of PRP that was 4 to 6 times baseline. It was 2 injections 4 weeks apart. And they found that the patellofemoral cartilage volume significantly improved in the PRP group. This is actually pretty cool because they used a 3D slicer software that calculated the area of the cartilage from the MRI image slices. So if you look at the image here on your right, the left images are your before pictures and the right images are your after pictures. After the PRP treatment, and you can see improvement of the cartilage quality and a bigger cartilage volume from the 3D slice image. They also found that the PRP group had significantly improved synovitis, and that there was better improvement in mean total VAS and WOMAC scores. So moving on to PRP for tendon injury. The most common tendons that have been studied using PRP is rotator cuff tendinopathy and common extensor tendinopathy. So for rotator cuff, majority of the studies are on PRP augmentation after rotator cuff repair, which majority of them has been positive. However, the studies have been mixed on the use of PRP by itself and not as an augmentation. This is the most recent data that we have. This is a systematic review of 12 randomized controlled clinical trials, 762 patients using PRP for partial thickness rotator cuff tears. So they found a statistically significant reduction in the VAS pain score up to 12 months. You can see the forest plot on the bottom of your slide here with PRP, favoring PRP on the left. However, they only found a statistically significant improvement in function up to 6 months. With regards to lateral epicondylitis, we can never forget Mishra's study, which provided some of the early evidence that showed high quality evidence of showing the improvement of common extensor tendinopathy with PRP. So this was the latest review to 2024 of 11 randomized controlled clinical trials, 730 patients, comparing PRP versus steroids. And they found that steroids only did good short term in less than 2 months, but the PRP group did better long term, more than 6 months in the VAS scores and the functional outcome scores. For gluteal tendinopathy, this is Jane Fitzpatrick's study, which is an RCT for chronic glute tendinopathy of more than 15 months of symptoms. 80 patients were enrolled, and they were able to show that one intratendinous, not around the tendon, but intratendinous leukocyte-rich PRP formulation under ultrasound guidance had a greater improvement in pain and function, which was sustained at 2 years. So this is more than 80% of the patients had a great improvement that was sustained at 2 years versus steroids, which lasted for a shorter amount of time. And in fact, in the recent Biologic Association meeting, she was showing their data on, I think, 4 to 7 years follow-up, showing still continued improvement in these patients and MRI, positive improvement in the MRI changes. Comparing all the tendinopathies together, this was one of the earlier systematic review of 16 randomized controlled clinical trials of different tendinopathies. And this was Miller's study, and they showed that the PRP was more efficacious than the controls, which included saline, local anesthesia, and steroid. Again, you can see the forest plot here on the right side. They found moderate treatment effect that continues up to at least 12 months. And the most common PRP formulation was more than 5 times platelet concentration of a leukocyte-rich PRP formulation. Another systematic review, meta-analysis of different tendon pathologies. This was by Fitzpatrick, 18 studies of more than 1,000 participants. Their follow-up was at least 3 months, extending up to 1 year. They showed that a strong positive effect of leukocyte-rich PRP and with a single injection under ultrasound guidance, and comparing to the different comparators of saline, steroid, local anesthesia, and dry needling, which did not have a positive outcome on the tendons. So with regards to dosing for tendinopathy, the impact of dosing is still less clear on tendinopathy. This was a narrative review by Peter Everts and a lot of the colleagues that are included in this webinar on the different PRP bioformulations and dosing for soft tissue pathologies, including tendinopathies, hamstring pathologies, meniscus lesions, and plantar fasciitis. So each of the studies are represented by the circles, and their platelet doses are depicted on the x-axis. And on the y-axis, this indicates whether the patient outcomes are positive or negative. And all the markers in blue demonstrated the positive outcome after PRP. So as you can see, the results of the studies from 1 to 14 did not show a significant difference when the PRP was compared to the control groups. And this was around, most of them have doses of about 1.5 billion, definitely less than 3 billion. However, if you look at the studies greater than 3 billion, specifically 3.2 billion, these studies have generally reported more positive outcomes. Again, this is Berrigan's meta-analysis systematic review. And these were the different tendinopathies that were included in the studies. As you can see, the platelet dosing is around 5 billion. The foot tendons and the lateral epicondylitis or epicondylopathy have less than 5 billion. And these were running right at around 3 billion doses. So the pathogenesis of tendinopathies are variable. There's a lot of them, and this might contribute to making it difficult to get conclusions on PRP outcomes and dosing. As we know, the pathogenesis can be either from overuse, from degenerative conditions, compressive lesions. They can also be neurogenic or inflammatory. So it will be harder to make conclusions, but we'll see how the data will evolve on tendons. So my take-home points are this. There is a strong high-quality evidence that supports that PRP improves pain and functional outcomes in knee osteoarthritis. There is growing research indicating greater benefits with higher platelet dose in joints and tendons, more so in joints. And a thorough analysis of PRP bioformulations is really necessary to understand their effect on outcomes. We will see that the interactions among these various components of the PRP, whether it's platelets, leukocytes, or others, are crucial in influencing its effects. And we'll see more of a synergistic role rather than just an individual cell concentration effect. So that ends my presentation. Thank you very much for your time, and we'll answer questions at the end of the session.
Thank you, Dr. Ambach. That was excellent. That was excellent. You gave us